Thank you so much for the opportunity to speak with you this evening. It is an honor to be included, and I certainly wish I was able to be there in person. I chose to speak about spindle cell lesions of the breast, as this is one of the most challenging diagnostic areas of breast pathology, particularly on core needle biopsy. Now, this topic is far too broad to comprehensively cover in a single lecture, let alone a brief session such as the one that we have tonight. If we look at this infographic of a number of different representative spindle cell lesions that you can see in the commonly in the breast, we can see that the opposing corners, the top left and the bottom right, or the bottom left and the top right, really bear little lesional resemblance to one another. But it very much exists on a spectrum. And this, I think, can start to create a lot of diagnostic challenge when we think about the lesions that we need to evaluate and rule out, particularly in a core needle biopsy, given that there can be significant heterogeneity of these lesions. The diagnostic differential of spindle cell lesions of the breast is in part made more challenging by the wide range of lesions included within this broad diagnostic category. Spindle cell lesions of the breast comprise both reactive and neoplastic processes, and the neoplasms that we do see can be benign, malignant, or of indeterminate biology. We see both low and high-grade processes, and these may be entities that occur specifically in the breast, or they may be processes that can arise anywhere in the body, including the breast. For the latter category, we must also contend with whether the sampled tumor represents primary or secondary involvement. For the latter, this could either be in the form of local direct extension or metastatic spread. If we think about the possible differentials in tabulated form, we're truly met with just a deluge of diagnoses. But fortunately, these lesions often, though of course not always, present with one of a few general patterns, which is going to form the basis for our discussion this evening. The first thing to consider for any case, be it a spindle cell lesion or otherwise, is the clinical presentation. Now, most spindle cell lesions are going to present as a mass. Additional characteristics of the lesion, though, can be very useful for adjudicating our differential. The location of the lesion is particularly important in how you define the scope of your differential. So is this a parenchymal lesion that's actually in the breast tissue, or is it arising from the chest wall? Alternatively, you can have cutaneous lesions or subcutaneous lesions that kind of extend down into the breast tissue. We next consider the demarcation of the lesion. So is this a well-circumscribed mass, or is it irregular and infiltrative? And this is often important for lesions that have had dedicated breast imaging. We next look at the rate of growth. So is this a palpable lesion, which can serve as a proxy for rapid clinical growth, or was it screen detected? If the mass is something that's being followed, we need to evaluate the rate of interval growth. So what is the change since the previous examination? Lastly, as is the case for really any sort of diagnostic evaluation, we need to contextualize the prior history. Of particular importance in the given diagnostic scenario are any prior history of surgery or radiation to this site, as well as any other history of other neoplasms in the breast. Alternatively, you can think about other neoplasms elsewhere, as the breast may be a site of metastatic spread. I next look at when I get a case under the microscope, I think about what are the components of the lesion that I'm seeing? Namely, is this a monophasic lesion or is it biphasic? For the sake of time, we will not be reviewing biphasic lesions today, but this is certainly a pertinent diagnostic category. Evaluating peripheral margins can aid this distinction, as well as providing additional useful information about the lesion itself. We should consider whether the periphery appears well demarcated, pushing, or infiltrative and entrapping. And for this latter group, we really need to make sure that we're not actually looking at a biphasic lesion. One thing that I find helpful when I see epithelial elements within a tumor is looking at the pattern of distribution. So if they're very regularly distributed throughout a lesion, that's more likely to represent a true biphasic neoplasm, though not always. If you can really still detect, though, kind of vaguely lobulocentric architecture, and they're not clearly arranged in a neat pattern throughout the lesion, that's more likely to represent true infiltration of the breast tissue. I next tried to broadly classify the lesion as either low-grade or high-grade. It is worth noting, though, that these morphologic patterns are not a surrogate for benign and malignant, as several unequivocally malignant neoplasms characteristically present with low-grade morphology. Conversely, an observation of nuclear pleomorphism or increased mitotic activity does not necessarily preclude a diagnosis of benignity. Common low-grade processes may show fibroblastic or a hypercellular pattern, and this low-grade class of lesions are more likely to represent kind of lesions that are instantly recognizable by morphology alone, as may be the case with mammary-type myofibroblastoma. High-grade neoplasms, though, include a broader range of diagnostic entities. And while there may be histologic clues that aid the diagnosis, such as a transition to epithelioid cytology in the case of metaplastic carcinoma, these lesions are seldom able to be diagnosed by H&E alone. And though undoubtedly of importance for low-grade lesions, the clinical context is paramount to accurate diagnosis of high-grade lesions. Now, no matter the components, no matter the margins, pattern, or grade, whenever you encounter a spindle cell lesion of the breast, you must always rule out metaplastic carcinoma. There are times when this can be accomplished by morphology alone, but it often requires ancillary studies such as immunohistochemistry. Memorizing or reciting the immunophenotype of common spindle cell lesions of the breast is certainly not the objective of this talk, but I do want to take a moment to highlight a few key concepts. First, let's look at CD34. CD34 is a transmembrane phosphoglycoprotein, which is expressed by a subset of mesenchymal progenitor cells, among other subtypes. CD34 is usually positive in PASH, myofibroblastoma, DFSP, SFT, as well as fibroepithelial lesions, at least focally. I will say that in phylloides tumor, as the lesion progresses towards malignant phylloides, though this can certainly occur in benign and borderline lesions, you often will lose the intensity of the CD34 expression, and you can have large areas that are completely negative for CD34. The next thing to consider are cytokeratins, specifically a panel of cytokeratins that includes broad spectrum cytokeratins, low molecular weight, and high molecular weight cytokeratins, in addition to P63. And this group of stains is really of necessary importance when evaluating or excluding metaplastic carcinomas. Although other lesions can express cytokeratins and P63, the staining is typically focal and limited to a single stain or maybe a couple stains. So in the case of phylloides, you may see some very focal staining for one or maybe two keratins, but you're not going to be seeing diffuse expression for a panel of keratins. Next, let's come to SMA. In my opinion, I would say that SMA is of extremely limited diagnostic utility, just for the simple fact that most of the lesions that we are going to encounter are positive for SMA, and nearly all of the lesions that we see in the breast can express SMA. There are certainly times where I will do this stain, particularly in phylloides tumors. I think it can be helpful, but I have to say, of all the stains that I do, I find this to be lowest on my list of the stains that are commonly referenced for spindle cell lesions of the breast. Lastly, let's look at beta-catenin. While this is useful in confirming a diagnosis of fibromatosis, nuclear beta-catenin expression is not specific to desmoid tumors, and two of the most important differentials, namely fibromatosis like metaplastic carcinoma and phylloides tumors, can show a similar pattern of staining due to molecular progression, where the finding of nuclear beta-catenin expression is something of a bystander effect. It's very important that we are aware of this pitfall, because seeing nuclear beta-catenin expression, of course, makes us think of fibromatosis, but it is not diagnostic, and we can really go down the wrong path if we render a diagnosis on that basis alone, particularly if we have not done a panel of cytokeratins. For the remainder of the talk, we're going to look at a selected group of case scenarios. We will start with looking at a low-grade fibroblastic and infiltrative tumor. We'll then see a hypercellular CD34 positive lesion, and finally we will look at a high-grade malignant spindle cell neoplasm. So let's start with the first, a low-grade fibroblastic and infiltrative tumor. On low power, we can see that there is diffuse involvement by a fibrotic and relatively uniform lesion. The tumor has vaguely fascicular arrangement, though it's not sharply defined. And we can notice that there is distinctly infiltrative growth at the periphery, both into adipose tissue as well as kind of trucking through these normal epithelial elements, in this case a lobule. On higher magnification, we see the lesion is composed of relatively uniform population of stellate to ovoid spindle cells present within a fibromyxoid stroma. And although prominent nucleoli are seen in some of the cells, the collective lesion really appears quite cytologically bland, and mitotic activity is relatively inconspicuous. So based on these findings, I applied a panel of immunostains. We can see that the tumor cells, though negative for A1A3 and CAM5.2, show diffuse staining for MNF116 and CK56, as well as for P63. CD34 was negative in this case. These findings confirm the diagnosis of fibromatosis like metaplastic carcinoma. I will say that this case really also emphasizes the importance of performing a panel of cytokeratins, as both A1, A3, and CAM5.2 were negative. That is certainly not an uncommon finding. Let's compare this lesion, though, to its namesake comparator, fibromatosis. I will say that both fibromatosis like metaplastic carcinoma and desmoid fibromatosis definitionally show infiltrative growth. So that's not going to be of help in distinguishing the two lesions. Both can show fascicular architecture. It's often more prominent in desmoid fibromatosis, but I will say that I've seen just as clear-cut fascicular architecture in fibromatosis like metaplastic carcinoma, so the architecture is not going to help you. Myxoid change can be equally apparent in both lesions. And by cytomorphology, I think that the cells are effectively morphologically identical. Both of these show these stellate to ovoid spindle cells, variably prominent nucleoli with these tapered cytoplasmic processes. And for all intents and purposes, I would say that the cells themselves are identical. Intralesional vessels, this is something that I will use for kind of positive predictive value for fibromatosis when you see this almost edematous halo around some of the intralesional vessels. I don't think it's entirely specific, though, and I would certainly never render a diagnosis based on this finding alone. Intralesional collagen is often more ropey in desmoid fibromatosis. However, you can certainly see prominent intralesional collagen in fibromatosis like metaplastic carcinoma. And similar to the intralesional vessels, I would never use that as being taken as diagnostic evidence of either lesion. By immunohistochemistry, CD34 is negative in both lesions. Beta-catenin. As we mentioned, of course, nuclear staining is seen in most cases of fibromatosis, though not all. But even though this case I'm showing here is a very tidy example, unfortunately, most instances are not going to be that clear-cut. We often get this kind of, cytoplasmic versus nuclear haze over the cell, and we have to try to adjudicate, is this just cytoplasmic staining or is this truly aberrant nuclear expression? Unfortunately, we can see a very similar pattern of staining in fibromatosis like metaplastic carcinoma, and you can even see true nuclear expression as we previously mentioned. So what will help us in determining the differential for these lesions? Cytokeratins are incredibly important. However, we have to be very conscientious about the stains that we choose to perform. Particularly, we need to do a panel of stains. We can kind of see that there's this very weak hazy staining in the example of metaplastic carcinoma shown here, but I wouldn't be totally convinced by that. This is AE1, AE3. Shown here, though, is MNF116. Now, this should not be taken as me saying that MNF116 is the stain to do. It could just as likely be the inverse pattern of staining here. What is important is that we do a broad panel of cytokeratins. In my practice, I routinely perform A1, A3, CAM5.2, MNF116, and CK56. Sometimes I also add 34 beta E12, which is another high molecular weight cytokeratin. Desmoid fibromatosis should consistently be negative for all of these keratins, as well as P63, which I also include in my panel of stains. What else should we consider, though? So if we take our diagnosis of fibromatosis-like metaplastic carcinoma, what about metaplastic spindle cell carcinoma? So we can see that this tumor also has some vaguely fascicular growth, but on higher power, we see that the lesion really has distinctly high-grade cytomorphology. And that is something that is the key distinguishing feature between metaplastic spindle cell carcinoma and fibromatosis-like metaplastic carcinoma. Fibromatosis-like metaplastic carcinoma is definitionally a low-grade tumor, which the tumor seen here is clearly not. What about fibrotic scar? So for either fibromatosis-like metaplastic carcinoma and for desmoid fibromatosis, there can be areas that resemble both of those processes, which are of course morphologically indistinguishable. For either of those lesions, though, not considering the recurrent disease, which can complicate the matter somewhat, we're not going to see the other characteristic findings kind of diffusely present within the lesion, such as foreign body giant cell reaction and hemosiderin. Remembering, though, that biopsy site change has to be taken in context, but in the case of fibrotic scar, we're often going to see this more diffusely present throughout the lesion. What about nodular fasciitis? So one thing that is very helpful is the recognition of these alternating zones of cellularity as seen here. The areas of lower cellularity can also show prominent stellate cells, which can certainly resemble fibromatosis. However, particularly when we look at the areas of higher cellularity, we're going to see more nuclear pleomorphism with a higher degree of mitotic activity, extravasated red blood cells, all of which are characteristic of nodular fasciitis. When we turn to immunohistochemistry, by far the most important distinguishing features here are the application of a panel of cytokeratins and P63. We'll note that all of the lesions that we've just reviewed are going to be negative for CD34, of course, positive for SMA. Beta-catenin is very helpful in looking at fibromatosis or desmoid fibromatosis compared to scar. However, it's not really going to help us all that much in looking at fibromatosis versus a metaplastic carcinoma. What will help us is the application of cytokeratins. And the thing to remember here is that cytokeratins will be positive in metaplastic carcinoma as well as P63, whereas they should be definitionally negative in the other entities mentioned here. The key point is that many different entities, both benign and malignant, reactive and neoplastic, can show significant morphologic overlap, particularly those with fibroblastic features. The next case scenario that we'll look at is a hypercellular CD34 positive lesion. On low power, we can see that there's diffuse involvement by a cellular proliferation, which on higher power is seen to be composed of ovoid spindled cells with bland cytology arranged in short intersecting fascicles with interspersed bands of hyalinized collagen. By immunohistochemistry, we see the lesional cells are positive for CD34 and desmin, whereas RB1 shows markedly diminished to absent nuclear staining. This, of course, then supports the diagnosis of myofibroblastoma. But what about these lesions? If we move clockwise from the top left-hand corner, we see that there's a cellular lesion with a greater degree of nuclear atypia, whereas here we see these slender, elongated spindle cells with more myxoid change in the stroma. In the bottom right hand, we see that there's a lesion with lower cellularity and more fibrotic stroma, whereas the lesion seen here shows distinctly epithelioid morphology, which of course raises concern for an invasive lobular carcinoma at the given anatomic site. However, by IHC, we saw that all of these lesions were found to be positive for CD34, positive for desmin, and had negative staining for RB1, indicating loss on a molecular level. This then supported a diagnosis of myofibroblastoma for all 4 of the pictured lesions. This, I think, emphasizes the point that a single diagnostic entity can exhibit quite protean morphology, as is often seen in myofibroblastoma. But what about this lesion? So this is also a cellular spindle cell lesion with areas that clearly resemble myofibroblastoma, at least to my eye. There are kind of these short intersecting fascicles with these round ovoid spindled cells. To me, this looks very similar, at least if we just look at the areas with spindle cell growth. Now, I'll note that there is adipose here, and adipose is also often present in myofibroblastoma, and that in and of itself does not indicate infiltrative growth. However, what I would not expect to see in a typical myofibroblastoma are these epithelial elements. Now, myofibroblastoma can rarely show infiltrative growth. However, in this case, the radiologic impression was that of a well-demarcated lesion. I think the lesion was around 0.6 centimeters. So I wouldn't expect to see a myofibroblastoma that was also infiltrative with those radiologic characteristics. By immunohistochemistry, I saw that this was a lesion that was positive for CD34, but it was negative for Desmond. RB1 is a little bit trickier to interpret, but definitive areas of loss were not seen within the stromal component. Just again shown here, though, I think that the stromal component of this lesion really does resemble a mammary type myofibroblastoma. The collective findings were taken to support a diagnosis of fascicular pseudoangiomatous stromal hyperplasia, or PASH. To me, this emphasizes a point that proliferations of a similar lineage, i.e. those that are myofibroblastic in origin, can bear resemblance to conventional neoplastic entities. For our last case scenario, let's look at a high-grade malignant spindle cell neoplasm. On low power, we again see diffuse lesional involvement with peripheral invasion. But on higher power, different from some of the lower grade lesions that we've looked at thus far, we see that the tumor is composed of markedly atypical spindle cells with frequent mitoses. We also see that there are some occasional rhabdoid to epithelioid forms within the tumor. And by looking at this by morphology alone, just taking common things being common, I was almost certain that this was going to prove to be a metaplastic carcinoma. However, my panel of stains did not support this. Everything was negative. So I did a panel of cytokeratins, as we discussed. All of those were very cleanly negative, as was P63. Now, metaplastic carcinomas can, in limited sampling, be negative for these markers. However, I wasn't totally satisfied with that. I thought about, okay, maybe this is, stromal overgrowth of a phyllodes tumor. CD34, though, was negative. As I mentioned, CD34 can be negative in phyllodes tumors, particularly as it progresses towards a malignant phyllodes, but I would expect to see maybe a little bit of staining, though I didn't totally exclude this differential. I next thought about, is there any way that this is just a primary sarcoma? So the patient had not had any previous history of radiation, but we know that primary sarcomas can arise in the breast in the absence of radiation therapy. Similarly, you can get metastatic involvement by an extramammary sarcoma. By morphology, I would have favored that this could have been some sort of smooth muscle neoplasm. However, all of my smooth muscle markers were negative. So it was negative for SMA, negative for actin, negative for Desmond. It was also negative for skeletal muscle markers, including MyoD1 and myogenin. So where does this leave us? Probabilistically, the most likely explanation would, at this point, still be metaplastic carcinoma, given that we know that on limited sampling, in particular, you can see the lack of cytokeratin staining, whereas when you get a complete resection, you're often able to identify areas of tumoral heterogeneity, stain those, which then can corroborate a diagnosis of metaplastic carcinoma. However, given this little limited sample, there was still kind of one camp of lesion that I had not excluded. And so I performed an S100 and SOX10, both of which showed diffuse staining. Now we know that particularly triple negative breast cancers can be positive for SOX10. However, this degree of SOX10 staining in the absence of all keratin or P63 expression was a little bit unusual. Certainly not diagnostic, did not preclude a diagnosis of metaplastic carcinoma, but it's unusual to see this clean of staining for both S100 and SOX10 when you have no staining for any keratin or P63. I would think of that almost as when you have kind of progression towards an anaplastic tumor as opposed to just aberrant staining. So I signed this out as an S100 SOX10 positive high-grade malignant spindle cell neoplasm. See comment. I will note that I also did additional melanocytic markers which were negative in this sample. Ultimately, the patient underwent further evaluation and had a complete mastectomy. And in that sample, we saw that there were cutaneous signs of regression in the excised skin, which ultimately, in addition to corroborating molecular evidence, supported a diagnosis of a spindle cell malignant melanoma, which was the final diagnosis. To me, this emphasizes that we should always rule out metaplastic carcinoma, keep it in our differential, but still cast a wide net. Coming full circle, we know that spindle cell lesions of the breast include a wide range of pathologic entities, but the approach to diagnosis can be aided by pattern recognition and an informed application of immunohistochemistry. The key points to remember are that different entities can show significant morphologic overlap. A single entity, conversely, can show quite protean morphology. Shared tumors and proliferations of shared lineage can show lesional resemblance, and we should always rule out metaplastic carcinoma. When we feel like we've done so adequately, it's always important to remember zebras. Thank you so much for your attention, and I'm more than happy to take any questions.